Dr. Patwari.
Yeah.
I have the patient I saw in room 26.
Oh, great. Yeah. Tell me.
Okay, so he's a 35-year-old man with a history of diabetes, and he's coming in today for 2 days of abdominal pain.
Mm-hmm.
The pain started pretty suddenly in the right upper quadrant after eating a high-fatty meal. It's sharp, constant, rating to the right shoulder, worse with eating, and no relief with Tylenol. So the pain started about a 5 out of 10, but it's worsened now to a 10 out of 10.
Okay.
And it's associated with nausea. He's thrown up, non-bloody, non-bilious. He said food contents. He had some tactile fevers and chills, but he denied diarrhea, constipation, and any urinary symptoms like dysuria or hematuria.
All right.
So he actually had similar pain, but not as severe, about 1 month ago after,
Mhm.
again, another high-fat meal. That pain lasted a few hours. It didn't really, it resolved without intervention, didn't recur, so he didn't seek medical attention. He does have a PCP. He last with the PCP about 6 months ago. He admits to drinking alcohol in the past, but quit one year ago.
Mm-hmm.
And he admits that he really kind of has unhealthy eating habits. And otherwise, he's not really sure what's causing his pain today.
All right.
So again, past medical, diabetes. He had pneumonia 5 years ago, and I believe altitude sickness about 7 years ago in Peru. For surgical history, nothing really significant, just a benign nevus removal in 2017. Family history was non-contributory.
Mm-hmm.
And then for social history, again, as I mentioned, he used to drink a few times a week, but quit a year ago, and no tobacco or drug use. Medications, he just takes metformin. Allergies, there's none. And then for review systems, it was just pertinent for polyuria and polydipsia. So on exam, he's afebrile 97.8, blood pressure was 150/90, he had a pulse of 90, respiratory rate of 14, and then he was 99% on room air.
Mm-hmm.
Generally, he looks well-groomed, well-nourished. He was in some pain. On HEENT, head was atraumatic, normocephalic, he had anectic sclera, pink conjunctiva, no needle discharge, some moist mucous membranes, and then the pharynx was normal, no edema, erythema, or exudates. Neck was supple, no bruits, no JVD. On CV exam, the heart was regular rate and rhythm, normal S1, S2, no S3, no S4, no murmurs, rubs, or gallops, no fetal edema. Lungs were cleared auscultation, no wheeze, no crackles, no distress. For his abdomen, he was non-distended. He had normal bowel sounds in all 4 quadrants.
Mm-hmm.
He was soft, but I did notice that he has some right upper quadrant tenderness
Oh, okay.
with voluntary guarding, no involuntary guarding, no rebound, no masses, no organomegaly, no fluid shifts or shifting dullness, and he was tympanic in all 4 quadrants, but did have a positive Murphy sign that I thought, yeah.
All right.
Okay, and then MSK was no tenderness, skin was warm and dry, no rash.
Yeah.
Neurologically, he was alert and oriented times 3. And then for psychiatric, he had a pleasant mood and normal affect.
All right.
So on results, he had a white blood cell count of 15, but otherwise that CBC was normal.
Okay.
And then on his CMP, his glucose was 350,
Ooh.
but then otherwise the CMP was normal.
Okay.
So my assessment is as follows. This is a 35-year-old gentleman with a history of diabetes. He's complaining of right upper quadrant pain for 2 days. On exam, he's hypertensive, and he has a non-distended abdomen with right upper quadrant tenderness, voluntary guarding, and a positive Murphy sign. So I think that this gentleman most likely has acute cholecystitis,
Mm-hmm.
and my reason for this is the location of the pain,
Right.
the radiation to the right shoulder,
Yeah.
that it was worse with food, especially high-fat food. He had associated nausea, vomiting, fevers, and chills. And again, that the exam findings of the tenderness and the positive Murphy sign would also be consistent with cholecystitis.
Okay.
The white blood cell count was elevated,
Right.
Which you can also see with cholecystitis. But
Yes.
his liver function tests were normal, and I know those can be elevated sometimes with cholecystitis.
Mm-hmm.
Another thing on my differential would be hepatitis, again, with this right upper quadrant pain and tenderness. But again, the LFTs were normal, which kind of would speak against inflammation of the liver.
Right.
And then lastly, he could have a pyelonephritis.
Okay.
He did have right upper quadrant pain, which could be atypical presentation. And he did have tactile fevers and chills and leukocytosis, which could suggest infection. But his CVA area wasn't really tender, and he lacked urinary symptoms, which makes this kind of less likely. So I think my diagnostic plan would be to get a right upper quadrant ultrasound to look at the
Good.
gallbladder.
Okay.
And then, because I mentioned pyelonephritis, let's check a urinary
All right.
analysis.
Good. Yeah.
Okay, and then therapeutic plan. He's still in a good deal of pain, and he's got that elevated blood pressure. So let's try some morphine. I think that would
Mhm.
help. And then I think if that ultrasound showed acute cholecystitis, that some of those findings could be like a gallbladder thickening, the wall being thickened, and like
Mhm.
some
Right.
fluid around the gallbladder.
Exactly.
I would consult general surgery. I think he would need a cholecystectomy and then some antibiotics.
Okay.
And then for education, this guy is really not following appropriate diet at all. He's not following diabetic diet. So I would suggest healthy diet for him, diabetic and low fat diet. And then the disposition, I think, would be admission to general surgery or right to the operating room.
Okay. That's a great presentation. Thank
Thank
you.
you.